Welcome to the Explore Global Health podcast. I'm Dr. Rob Murphy, Executive Director of the Havey Institute for Global Health here at Northwestern University Feinberg School of Medicine. Today, we are thrilled to welcome Dr. Luis Pizarro to the show. He's currently the Executive Director of the international nonprofit medical research organization, Drugs for Neglected Diseases Initiative, commonly referred to as DNDi. A medical doctor and global health expert who was born in Chile, studied in France. He holds not only a medical degree from the University of Paris, but also a master's degree in political science from Sciences Po, and an executive MBA from a joint program of EHESP, School of Public Health, the London School of Economics, and ESCP, European Management School. After working as a clinician early in his career, Luis led medical projects for several years in West and Central Africa, in Francophone countries, and leadership roles at global health nonprofits. Since September 2022, Luis has been the executive director at DNDi, which is based in Geneva. DNDi discovers, develops, and delivers medical treatments for neglected populations. Today, we're going to trace Luis' career journey from his clinical roots to his current role in global health leadership and learn how his experiences shaped our commitment to building common good for the future. Welcome, Luis.
Thank you very much, Robert, for your invitation. Very happy to be here.
Thanks for joining us today. Let's go back to the beginning. Your early years as a child growing up in Chile. This is the part, actually, I know the least about you. Tell me about your family, your upbringing, what led you to eventually leave Chile and pursue a medical degree in Paris.
Yeah, long time ago, but it's an important, I think, historical moment. We can remind that now because I was born 1973 when Pinochet did the coup d'etat in Chile. So I spent my first 18 years living under a dictator in Chile with an important social movement, not only for democracy, but I would say also for a more social justice in the country. So definitely my first 18 years in this country were fundamental, I would say, for my willingness to spend my career working against those injustices. I had the chance to have a grandfather who was French and so get the French nationality. So I had a possibility to go to France to do my medical studies. And being, in Paris, during my medical studies, I met colleagues from Médecins Sans Frontières, Doctors Without Borders, and I understood that, everything people call humanitarian action, emergency medical interventions was very, very exciting and very inspiring aspect of the career. So probably those are two important elements that explain why I'm here today.
Which medical school did you attend in Paris, and how did you end up at that school?
I ended, to be honest, without knowing too much in Paris, and I went knock on to the door and asking which one would accept me. I was lucky enough, to get one called Cochin, that is in center of Paris, well known for infectious disease, but also for rheumatology and other specialties. I learned that sometimes those universities are very far, I would say, from what a medical family doctor will do, a GP will be practicing in his daily life. And obviously, the medicine I was learning was very far also of the needs of many of the population in the world. So I think it was academically very important for me and brought a very scientific perspective to my career. But definitely what I do today, it's a mix between that and what I have learned in my different professional experiences.
How were you first exposed to the idea of global health? And was there a turning point or some kind of spark or event that made you want to pursue global work as a career instead of staying in Paris or some area of France and practicing medicine?
I would say in the 90s, when I was doing my medical studies, global health as a concept was not really there. So what people were using sometimes tropical medicine or international medicine. And for doctors, it was more about practicing, in low and middle income countries, to be honest. So we had the example of NGOs like, as I said, MSF, Doctors Without Borders, and we thought that our mission will be to go treat people that were abandoned, let's say, by their health system. The real global health concept, that it's not, being interested in health in other countries, but think about transnational issues of health, came to me later in the 2010, after being in Niger for 2 years, because I understood that more and more we have health issues that cannot be managed by one minister of health or within, national borders, and need an international cooperation, international solidarity. So I would say probably two steps. The first one was to go and try to work where the needs were bigger. And the second one came after understanding those international connection, interlinks you have in global health.
Let's jump up to 2004 when you joined Soltis. Well, that's an acronym. You're going to tell us what that is. It's an organization, still exists, doing very well, initially involved in the fight against HIV/AIDS in Africa. You already mentioned you were first head of the mission in Niger, and then became CEO in 2006. And I think that's about the time we met, a role you held until 2020. So tell us about Soltis and how you helped that organization evolve over the 15 years or so that you ran that group.
In the early 2000s, the international community understood that it was not possible to keep the situation with most of the HIV patients were in low and middle income countries, and particularly in Africa. And the new treatments that were, saving lives, that were really breakthrough in the medical space were only for American and European patients. I think we were part of this movement that was trying to break this absolutely unacceptable situation and try to make reality treatments for the most neglected. So I had the chance to meet in Paris in the Pitié-Salpêtrière Hospital, very, very inspiring and motivated group of doctors like Christine Catlamin, like Gilles Brucker, who had the chance to receive from a private foundation, Bettencourt Foundation, resources to support West African countries in order, let's say, to implement therapeutic programs for HIV. At the beginning, the model everybody had in mind was the MSF model. So people were thinking, we'll go to Mali, we'll go to Niger or to Benin, we will put in place some treatment, programs with the treatment facilities. We will hire doctors. We will buy drugs. We'll buy tests, and we will stop treating patients. And when I arrived to Niger with that in mind, I realized very quickly that the Nigerian doctors were not looking at this. They said, but why are you going to do that? Why you don't help our hospital, our national program to be sustainable and to do that ourselves? And we immediately switch what we had in mind, and we transformed this program into a sort of health system strengthening program. So we started training all the health workers. We advocate with the World Bank at the time, the Global Fund, who was just starting at this time, to say the money has to go to the national program to Nigerians, and we will be there as sort of technical assistance, supporting to select the best guidelines, the best tests, and after 5, 6 years, being able to leave and let those colleagues working alone. So that was absolutely fundamental, I would say, in my career, is to understand that if you want to do something that is really sustainable, you need to start by listening those you want to help because you don't know better than them. And you need to work really at the roots of those national programs to support in a very, I would say, national ground based approach the work we're doing. So, really key in my career.
Yeah, that was simultaneously in the United States the beginning of PEPFAR, the President's Emergency Plan for AIDS Relief, which was a fantastic public health program that I was the country director in Nigeria, and it was the same thing. It's impossible for a group of doctors to go over there and take care of the entire country. It's not going to work. And we had to increase the capacity.
And I think what we understood also is that many people have, very vague ideas about the African situation, the Latin American situation, or the Asian situation. And they think at the time they were talking about HIV/AIDS, that the situation was the same everywhere.
Everywhere.
You remember Robert people saying HIV in Africa. And we realized that that meant nothing at all because what you were seeing in Nigeria was completely different from the situation in Niger and was different from the situation in South Africa. So the need to be extremely tailorized, I would say, in the way we approach that and try to stick to the needs we discover in each place, it's absolutely fundamental for the work we do.
Can you tell us what is the acronym SOLTIS? What does it actually stand for?
Well, at the beginning, in French, you will say solidarity, therapeutic, so SALT, initiative. For S was SIDA. SIDA is AIDS, HIV/AIDS. After 5 years, as I said before, we realized that not only we needed to work, the roots of the HIV national program, but in a country that is facing so many health issues from sexual and reproductive health, infectious disease, and more some non communicable diseases like diabetes and others, we couldn't only live in a bubble and focus on HIV. And when you look at the situation today with, the completely stop of some international fundings, I think everybody now understands that we need to work on the health system with domestic resources and having a very sustainable program in the long run. So at the end of the day, we change. It's still Soltis, but it's more focused on a sort of solidarity for the health system in the long run.
When you became CEO in 2006, it was a relatively small organization, I believe. And then when you left in 2020, I think it was had grown quite a bit. Can you tell us a little bit about the growth of Soltis under your direction?
The impact is what was driving this growth, I would say. Another good example for me was Guinea. And the example of Niger started to be known in West Africa. So I received colleagues from Guinea who came to Paris and said, listen, in Guinea, everything is managed today by international organizations, the German, the Americans, the Italians, but none Guinean health teams is in charge of HIV patients. What can we do together? And I remember to go there, discuss not only in Conakry, in the capital, but also, we went through the different places near the mine sites because you have a lot of sexual and reproductive health issues around mines, as you know well. And we decided, to start training people and put in place real national health facilities to work here. And this example was spreading more and more. So after that, we went to Sierra Leone, we went to Burundi, we went to Ivory Coast, etc., etc. I think when you're able to show, results, when you're able to show the impact of what you're trying to do, it's definitely the best way to expand the work your organization is doing. And maybe the second also good driver of that was when people feel you are solidar with them, but really solidar. So when we were in Guinea and Sierra Leone, the Ebola crisis started. And many organizations left because it was dangerous, because people were absolutely scared on this situation, and it's normal. We were all scared about that. But when you try to do your best to stay, to support national colleagues, national authorities, to do whatever it's possible in this absolutely enormous crisis, people after that know that they can count on you when the situation is going bad. And you're not just there, to get this international funding that was enormous at the time, but that you're really working with them in a daily life and trying to address local problems together. So, as you said, we were lucky enough to bring more countries to work with us to expand this international solidarity approach. And we were lucky too to have international organizations who supported our work. We started with this foundation. Then we had a very, very good partnership with United. We had also very good partnership with French actors, the French Development Agency, or like Expertise France. And we had this very good collaboration too with the Global Fund. So it's a mix of showing impact, having a close relationship with the people you're here to support, and also being reliable to the international donors that are supporting your work.
So after Soltis, you moved to Unitate, also based in Geneva. Unitate is part of WHO. This group focuses on making new health products available and affordable for people who need them. What was your role there? What was it like working for an agency of the WHO?
I moved from, let's say, an NGO doing the work we do in different countries and also looking for fundraising because let's be very honest, when you are the CEO of this type of organization, a big part of your time is about mobilizing resources to be able to implement those programs. And now coming to United, I changed because I was in the donor, position. And you have a very, very, very important responsibility because you are funding many organizations that has real impact in the field. At Unitate, what was also absolutely exciting for me is that it's not just the classical donor, giving money to an NGO to buy treatments or treat patients. It's promoting innovation in the health and scientific field. So was trying to scan where are the most interesting innovations in terms of infectious disease mostly, and trying to see how we can bring this innovation to the patients who need the more and build this sort of, value chain, trying to think about, what will be the cost of this, how to register those drugs into regulatory agencies, what are also the best programs to implement that? Because you can have, for instance, a self test for HIV, an oral self test. So this is a revolution. People can test. I mean, you need to confirm, of course, but it's a revolution, in the HIV program. But what is the best way to bring this test to the patient? Is it through the classical public health program? Is it through hospitals or very small health facilities? Do you need to go through the community and civil society organizations? And once the patients are tested, how you ensure that they will come back for treatments? Because you want them, of course, to be treated and to be in good health at the end of the day. This is the final impact. You're looking for that. So you need to think about different ways of implementing that, control, get some information on this, and inform WHO guidelines and national guidelines on how to do a good test and treat program. So I was in charge of everything related to HIV, to sexual and reproductive health. I worked a lot also on IP, intellectual property, and access, like, for instance, the medicine patent pool we were funding and supporting, very interesting programs. And during those 2 years, also happened COVID crisis. So Unitate asked me to follow how we could strengthen health systems to face this COVID crisis, and how, with the colleagues in FINE and in other institutions working on diagnostic, we could, improve and develop access to COVID tests during the pandemic.
Amazing. And now you're executive director of DNDi. You lead an organization rooted in equitable, patient centered research and development. What drew you away from Unitaid to DNDi, and what sets this organization apart from the other global health not for profits that you've worked with?
You have, of course, the classical public organizations, bilateral agencies, UN agencies like WHO or UNICEF, and you have those groups like the G7, G20. All of them will be 100% government driven public actors. You have another one is the private sector with non-profit private sector like NGOs and foundations, philanthropy. And of course, the for profit one like the pharma sector, consultancy, you know them very well. And in between those two groups, we have public private partnerships. In global health, we call also global health initiatives. Within those global health initiatives, there are the funding mechanisms like the Global Fund, Gavi, Unitaid, I mentioned before, that are channeling funding from those big governments to local authorities and actors in the field. And you have what people call product development partnerships. So organizations that are investing, their time, their expertise to develop new health products like vaccines. You have IVI, IAVI, them probably. Some others working on diagnostics like FINE, and some others working on therapeutics is the case of DNDi for neglected diseases, MMV for malaria, or TB Alliance based in New York for tuberculosis, right? So our mission is really to address the gaps, the classical pharmaceutical R&D model driven by, of course, profit, the gaps this model is not addressing at the time. If you take neglected diseases, for example, when DNDi was created 20 years ago, neglected diseases were affecting 20% of the global population once a year minimum. 20%, 1.6 billion people in the world, and less than 1% of the total research was focusing those diseases. We call that the fatal imbalance, and that was the reason why MSF receiving the Peace Nobel Prize said it's unacceptable. They went and looked for WHO, research institutions in Brazil, Kenya, India, Malaysia, Pasteur Institute, and they said, people, let's come together around the table and let's think about what can we do, to address this absolutely unacceptable imbalance. And solution can be maybe simple for you, but now it's working, was to say that at the end of the day, none organization will do alone this amazing work. So we need to be able to bring around the table different institutions, the philanthropists like the Gates Foundation, pharma companies like Sanofi, for instance, or Novartis that are working with us, the academia, research institutions, and of course, the patients, the communities, the countries where those diseases have the strongest burden. And it works. So this is, I would say, what we do at the NDI and what we try to promote.
I understand DNDi has delivered 13 treatments and has even more in the pipeline. Can you just walk us through a little bit more how DNDi actually develops the drugs outside of the traditional profit driven model that you've described?
It has always to start with the patient needs, and the patient needs to stay all along, our journey to bring a drug. So we work with patients, of course, with health workers. Safety, it's a major requirement for that. It has to be something that is accessible because if you bring the best drug, but it's too expensive, of course, you are not fixing the issue of neglected population. It has to be also something that it's feasible. So if you develop a drug that you will use in Congo, in Guinea, but that need a fridge because it's not heat stable, it doesn't work neither. What is the logistic you will need to put in place for that? So having what people call the product profile, TPP, target product profile, and discuss this with the people who need the drug, it's absolutely fundamental. And after that, well, you will have, of course, the preclinical work, the clinical trial work, and then how you register the drug and how you bring the drug to the patient. And our work will depend where the science is. If there is nothing, we need to start from scratch. And we need to discuss, with biotechs, discuss with some pharma companies and with some research academics how we can do preclinical work, how we can use today artificial intelligence, for instance, to go faster, in this research and try to fill the pipeline with molecules that will be good candidates for clinical trial. If we're lucky enough to have a molecule that is already tested for other diseases, but that could be a solution for the disease we have in mind, we can start at the clinical trial level and boost, let's say, the work we do with, of course, national health workers, national ministers of health, and honestly, do the best science, the best clinical trials wherever is needed. But you need to work, of course, very closely with your national partners. And sometimes it happens that the drug is there, that it works for the disease, but it's not yet in national guidelines or it has not been registered in the national regulatory agencies. So our work could be much simpler if how we're able, to make this happen and make this accessible for the neglected populations.
You've shared some critical knowledge in global health that can only be gained by working and engaging directly with patients in their communities. For example, when you're talking about the Democratic Republic of the Congo, I understand that through your work with the stakeholders there, that one of the things that was not acceptable to the community was actually tablets that were white colored and that they preferred tablets that were black colored. Can you tell me more about this observation and others like it that help you implement your projects even better?
Well, of course, when we're young, we think that we know everything. And when we're a doctor, it's even worse. So, humility, the capacity to listen and not to try to convince others always, it's something that, well, for me, took time, and I have to admit, but that I realize today how important it is to be relevant in the work we do. And that's why the example you're giving, it's a very good example of you can invest millions, you can spend 10 years working in drug development, but if you were not humble enough at the beginning to take the time to listen to people, what are their needs? What are they really looking to improve their life? You can be completely out of the box and waste your time and your money on that. This is why it's also important to bring social science here. You and I are medical doctors. We are, let's say, the classical scientists working on this, but we know very well that in order to understand those social phenomena, we need our colleagues from social science to work closely with us to understand those topics. I remember when I was in Niger, we were developing a program about PMTCT, how to prevent the transmission from mother to child of HIV/AIDS. And we did everything by the books, right? Training people, bringing the best drugs, having the best tests. Everything was there and it was for free. So we were convinced with our national partners that it will work. After 6 months, only 40%, 50% of pregnant women were coming back to take the drugs. Everybody was like, wow, what is going on? And so we looked for social scientists, that were based in Niger, and we asked them to do some research, some social science research to understand it. Of course, some of the reasons were very critical and were cultural because women didn't want to inform their families and their villages that they were infected by HIV/AIDS. They were worried that they will be exposed and they will not be able to stay in their families, in their communities. Very difficult to address that, and it's not an international NGO that can fix this. But the other reason that was given is that the patient flow, the organization in the hospital was too complex. And women had to stay sometimes 2 days in order to get the treatment, etc., etc. And this is something we were able to fix with our national partners. And after 6 months, we improved almost by 40% the loss to follow up patients we were treating. So this is absolutely key to stay connected with the reality, to be humble, to listen to people, and to bring other expertise with us. I talked about social science, but it could be economists working with us, people from the legal aspects, etc., etc.
So we've touched on this whole factor about shifting more research, leadership, and input to the global south. Where do you see this going in the next 10 years?
If we do this work, we need to find opportunities and constructive, positive elements everywhere to move forward because the ones who are suffering are not you and I. We live in countries that are secure. We have our salary at the end of the month. So let's be very honest. We are not the ones suffering here. The ones who are suffering are the patients who are not receiving any more vaccine, drugs, or communities like the LGBT communities that today are completely isolated with the new program. So let's be very, very clear on this. We will be I think, in a very fragile balance between the positive things in terms of empowerment we are hearing from regions, Latin America, Africa, Asia, some countries saying it's time now to take our needs in care by ourselves, and we need to invest more domestic resources. We need to take care of our population. And I'm very happy to hear that more and more governments, more and more politicians are understanding that health is absolutely key for the countries, and it's not something they can let, international organizations managing outside. So I'm very happy about that. Nevertheless, as I said before, we need to be very careful also that the people we're serving are the neglected ones. And of course, they are neglected by a pharma system that it's driven by profit. So the poor people are not interesting. That's true. But they are also neglected sometimes by their own governments. And we will stay very close to those patients because we know that neglected people will be more and more in the years to come. So let's try to navigate, around that. The second optimism I have is that it's not only about countries, it's about region. Look at Africa CDC, African Medicine Agency, Africa Development Bank. Do you remember 5, 10 years ago? We were not in the situation we are now. There is a new generation of African scientists that are taking the lead that came very motivated with a lot of expertise they gain in some other countries, etc. And they are now really trying to move lines in the African continent. And I'm very happy of that. I see the same in my continent, in Latin America. More and more young researchers, young doctors want to, shake a little bit the status quo where they were. And you see that in Asia with a lot of new things coming. So, country like Indonesia is being a very strong leader in the Asian region. They are now taking part on, for instance, the effort. We are working a lot on that. We have a South-South alliance with people from Asia and Latin America. And we know that countries like Singapore, Malaysia, Thailand, Sri Lanka, Indonesia, they are not waiting for Europe or US to come and fix their problem. They are now saying it's our issue and we need to do something for that. So I would say those are positive trends we need to really push for. What is probably scaring me a little bit more and we'll need to follow is what's going to happen with the research in the pharma sector. The big pharma is not interested anymore in infectious disease. We're very conscious of that. And what is going to happen with all the outsourcing they are doing? They are not doing so much R&D, but buying biotechs. They are outsourcing manufacturing. So I don't know how those changes we're seeing in this ecosystem will impact the capacity, to continue doing the work we're trying to support.
I have one final question that I ask all my guests on this podcast, and that is, what advice do you have for young people who are just now embarking or considering embarking on a career in global health?
I will make the difference first between, the health students that would like to work outside of their countries. So they have more, the sort of traveling approach that honestly, it's something you learn a lot and it can be very inspiring, of course. But it's something to be managed with attention, with humility, as I said before. And for me, it's not really global health. It's just going somewhere else, do the job of doctor you can do in your country, and that's it. A completely different aspect is students that are, engaging in the real global health sector when we talk about global health issues, those that are not managed at the national level and that are very multidisciplinary, right? So you can have your own health background, but you need to understand economies, you need to understand politicians, you need to understand legal, etc. And you need to be able to embrace this complexity, this multidiscipline, and think outside of your, let's say, small box we have as doctor or as economist, etc. My first recommendation is really to make this difference. And if you go in global health, open, to different disciplines. The second one is to be very clear also what you want to do. Do you want to be an expert in something? So you go for a PhD and you become very, very, focus on sexual and reproductive health, economy, this or that, doesn't matter. But you are an expert and you are putting your expertise at the service of a country, of an international organization, or whatever. This is different from being a project manager, a team manager, and then do the job I do, for instance, as the CEO of an international organization. Here, you need to not only be good, for instance, on health on this, it's important, but it's not enough. You need to be able to develop management skills, leadership skills, and, a political understanding of what is going on. A third part that it's also very important and our students are forgetting is all the support functions we need in our sector. My colleagues doing finance, human resources, communication, fundraising. Those are very, very important functions we need everywhere in the global health sector. And you can think about that too. And for instance, my colleagues doing fundraising, external relation, they do a great job. They engage with very different organizations. They need to think how to design a project, then, how to convince donors to come here. So those can be also very exciting, jobs you can do in global health. So think about that. What do you want to be? An expert, a manager and leader, or you want to support the organizations in different aspects? And when you think about that, let's try, let's explore. And again, humility in everything you do.
Louis Pizarro, Executive Director of DNDi. Thank you so much for joining us today. We really appreciate your comments and your insight and wish you luck in the future. Follow us on Apple Podcasts or wherever you listen to podcasts to hear the latest episodes and join our community that is dedicated to making a lasting positive impact on global health.